Our first and keynote speaker is Dr. Budoff. I had the pleasure of meeting Dr. Budoff maybe about 25 years in Hawaii at a conference where we lectured. And we've tried to have him come and speak on a few occasions, but schedule did not allow. And this year, through the kindness of Dr. Wright, we got Dr. Budoff to come and speak to us today. Dr. Budoff is professor of medicine at David Griffin School of Medicine at UCLA and the endowed chair of preventive cardiology at Harbor UCLA Medical Center. He's a graduate University of California at Riverside, but graduated a member of Alpha Omega Alpha from George Washington University School of Medicine. Dr. Budoff has authored or co-authored more than 50 books and book chapters and more than 1,000 articles. He has received numerous research grants from the NIH. In addition to his 2015 appointment as endowed chair of preventive cardiology at Harbor UCLA Medical Center, he has been recognized for his work by the Society of Cardiac CT, from which he received the Gold Medal Award and recently designated as Master of Society of the Cardiovascular CT. Dr. Budoff will be speaking to us today on a very important topic, screening for heart disease. Welcome.
Thank you.
Thanks for coming.
Thank you so much, Dr. Khan and Dr. Khan, for this wonderful course. And of course, when Dr. Wright tells you to come, you show up. So all good there. But thank you very much. It's really a pleasure to be here with everybody. And as Dr. Khan already said, thank you for braving the weather to make it out. So hopefully I'll be able to take you through a little bit of some of the newer guidelines for screening, and then talk a little bit about maybe where we're headed with cardiac CT and CT angiography as a potential screening tool for certain patients. My conflicts of interest. So why do we need new screening tools? We've been using these risk calculators for decades now. We had the Framingham risk calculator, and then there was a number of new risk calculators. This is the American Heart Association, American College of Cardiology pooled risk equation. And this is from Northern California. This is actually work from Jamal Rana, over 300,000 patients. And in orange are the expected event rates based upon the pooled risk equation. So those numbers there is what should have happened, and in blue is what actually did happen. And this is not very good calibration. That means that we're over-predicting events by about fourfold. And when you're 400% off from reality, that's probably not where you want to be for risk stratification. So we overestimate risk, and you can argue, well, that's not terrible because it's better to overestimate risk than to underestimate risk. But the problem is that you don't get good compliance when patients don't believe or perceive that they really need to take these therapies. And without taking these therapies, be it lifestyle, diet, exercise, be it blood pressure medicines, like we'll hear about a little bit later, or whether it's the lipid-lowering therapies, these are important treatments, and if you don't take them, they don't benefit you. So we need to match intensity of risk with intensity of therapy. So how can we reduce the pooled risk equation to get people back into line? And I'll show you where the guidelines are taking us and where the science is taking us to kind of better calibrate these so that we can identify who's really at risk and then get them on appropriate therapy. So coronary artery calcium now is, 25 years ago, it was emerging. Now, hopefully, it's something that people understand, but it's calcified plaque in the coronary arteries. And it's not necessarily the most vulnerable or dangerous plaque, but it's a good marker of overall risk. So kind of like an iceberg, this is from Dr. Rumberger, who was at Mayo at the time, came up with this analogy that the calcified plaque is kind of like an iceberg in that it shows you the overall disease by kind of showing you the tip of the iceberg. And calcified plaque is very exciting to measure because it's easy to see. We can see it on a CAT scan. We can even, on extreme cases, see it on chest x-ray. We can see calcification of the coronary artery. So it's the easiest plaque to see without contrast and injections and all of that. But the analogy is really, imagine the Titanic going downstream and it sees an iceberg off its bow. It doesn't say, let's send some divers below the surface of the water to see if there's anything there that's going to rip the hull. They know that they're in trouble. And the same thing is true with coronary calcium. When your patients have coronary calcium and we have this calcified plaque here, I guess I'm doing that wrong. Sorry. I'll use it later. The calcified plaque in the upper corner, we know that that represents about 20% of the total plaque in the coronary arteries. So they're going to have fibrotic plaque, and they're going to have that lipid-rich or that vulnerable plaque as well. And the bigger the iceberg, the more coronary calcium, the bigger the problem. So we can identify who's at risk by who has a higher calcium score. And the score is very simple. It goes from 0, no calcium, to a very high number into the thousands. And it's just a volume of calcified plaque, but it tracks linearly with total atherosclerosis. So the higher the score, the more atherosclerotic heart disease you have, and thus the higher the risk. And this has been shown in a number of large trials, but really caught the attention of most of the guideline writers and policymakers with this paper. This paper was published in the New England Journal of Medicine, 2008. You can see a calcium score of 0, being very low risk. So it's like golf, low score wins. So 0 is great. And about half of us would have a score of 0 today. About half of us are going to go on and develop heart disease, and about half of us will ultimately die of cardiovascular disease. So it's a good marker of which half you're on. Imagine it like the mammogram, where we do mammography to identify which women are going down that road of breast cancer versus not developing breast cancer. And my boss, Bruce Brundage, who was up in Bend, Oregon for many, many years, after he left Harbor, always told me this is the mammogram of the heart, that this is going to be the test that we use to identify who's going down that road of atherosclerosis, and then we can act on those patients differently than the people who have scores of 0 who are not going down that road. But as the score goes up, your risk goes up. So you have a little bit of coronary calcium, a score of 1 to 100, you're about 4 times more likely to suffer a heart attack or death. If your score goes above 100, you're about 10 times more likely. And if your score goes above 300, what we call severe calcification, you're about 14 times more likely to suffer an event. And we'll come back to that number 300 and 100 because those are important cut points when we talk about treatment. So Dr. Detrano, who did the original paper, was at my institution, so I did this follow-up paper looking at 10-year outcomes, because we like to think about things in the next 10 years to kind of identify who needs treatment, and we always do these 10-year risk calculators, and when you blow up any of the 4 boxes, they all look similar, but you can see that in very faint, on the very bottom, not well seen here, there's a line of calcium scores of 0, and 0 stays very, very low for the entire duration of 10 or 12-year follow-up. If your score is 1 to 100 in that light white bar, it eventually crosses the line of identity. Let's try this again, right about here. But that takes 10 years to even get to a 7.5% risk, so that's generally considered a low-risk patient, but they do have a little bit of atherosclerosis. But if you're in these other groups, these patients who have calcium scores above 100 in gray or above 300 in black, you are in a much higher risk state, and your event rates are now going to be very significant. And these are the kind of patients that we want to be more aggressive with because their short-term risk is high and their long-term risk is very high. So we tried to look at, in MESA, the multi-ethnic study of atherosclerosis, pretty much every possible risk marker to say, well, which one is best? And it wasn't always thought that coronary calcium would be the best risk marker. A lot of people thought things like C-reactive protein would be a good marker of risk, or people thought that maybe ankle brachial index to identify people with peripheral vascular disease would be a good risk marker. or carotid IMT, abbreviated here as CIMT, would be a good risk marker. But if you look at the net reclassification index, in other words, how often does it help you, those numbers are quite low. In other words, CRP, not very helpful. It reclassified 7% of patients. It did not reclassify 93% of patients who underwent that test. Carotid IMT reclassified 10% of patients. It didn't help in 90%. But coronary calcium reclassified 66% of patients. 2 out of 3 patients who underwent the test were told, no, you're not intermediate risk, you're high risk, or you're not intermediate risk, you're low risk, and it reclassified them appropriately. So coronary calcium was seen as the best risk marker among all of the markers that we studied. And this is not only true in this study, the multi-ethnic study of atherosclerosis, but in about 8 other cohorts as well around the world. So this has emerged as our best risk marker to date. So how can we use that and be comfortable? Because coronary calcium doesn't show us soft plaque. It doesn't show us and there are going to be some patients who have no coronary calcium but have a little bit of soft plaque. And luckily, that doesn't invoke much risk. If you look at that red circle, that represents 23,000 patients. This is from a Denmark registry, a Danish registry, and they have closed healthcare system there, so the follow-up is excellent because they know what happens to everybody in the country. And you can see over a long period of follow-up, if you have no plaque and a calcium score of 0 in brown, your event rates are very low. That's 6 per 1,000 or 0.6% risk. If you have no calcified plaque, a score of 0, and you have a little bit of soft plaque on a CT angiogram, we see a little bit of soft plaque, your risk is very low, 0.6%. So finding a small amount of soft plaque, if you have no calcified plaque, your plaque burden is low and your risk is not elevated. Even if you have soft plaque that's causing a 50% blockage in blue. So this group here, 50% blockage right there, and a score of 0, your risk only goes up to 0.8%. Still very, very low. Now, once you start having calcified plaque and soft plaque, your plaque burden is going up, your risk goes up. And you can see by the time you get to a score of 100 with either non-obstructive disease or obstructions in the coronaries, your risk is quite high. So we can be comfortable that a score of 0 really tells us that even if you have a little bit of plaque, it's just a little bit of plaque and it's not very dangerous. So a score of 0 is a good way of de-risking patients, saying that you're fine for now. It's not a lifetime guarantee, but we give people a 5-year guarantee that they're going to be a very low risk for heart attack, stroke, or cardiovascular death. The one biomarker, and we've tried this with a lot of biomarkers, C-reactive protein doesn't help. Other biomarkers don't seem to help. We looked at many, many biomarkers in the Framingham study with coronary calcium and in MESA. The only biomarker that we can show that imparts more risk on top of a coronary calcium score is actually a high sensitivity troponin. So we're not talking about the troponins you get when they go to the emergency room and have a heart attack. We're talking about just a healthy person, you feel fine, your doctor orders this high sensitivity troponin and it's abnormal, meaning your heart has a little bit of maybe microscopic plaque rupture or a little bit of damage going on, subclinical damage, and this is now detectable. And it actually proved to be quite a powerful additional marker. So if you look at the bottom light blue line, that's a calcium score of 0 and non-detectable troponin, and you're very low risk. In the red line, if you have a little bit of coronary calcium, or if you have just a little bit of troponin on the red line, but your calcium score is 0, you have a little bit more risk, but you're still very low risk. The gray line up here, this gray line represents a calcium score that's positive without troponin, and you're at increased risk because you have coronary calcium. But look at this line way up at the top. That's calcium and high sensitivity troponin. So not only do you have plaque, but the plaque is having probably small amounts of rupture and activity, and that puts you at a much higher risk. So I think you're going to see over time that this test, this high-sensitivity troponin, will replace high-sensitivity C-reactive protein as a way of stratifying patients who are asymptomatic, who might be having active plaque and might be at increased risk. It quite hasn't made the mainstream yet for clinical practice, but the data is quite good as compared to C-reactive protein. Now, you don't need a calcium score. These machines are pretty much now everywhere. They used to be pretty rare, but now almost every CT scanner can do a calcium score. It's not that hard a test, but we have other clues. When you get a lung CT, let's say you get a low-dose lung CT for smoking risk and you're getting lung cancer screening, or you go into the emergency room because you have chest pain and the doctor does a CT scan to make sure you don't have a pulmonary embolism, you can get coronary calcium assessed. And this is just a semi-quantitative. Is there a little bit of calcium in one artery? Is there a lot of calcium in all three arteries? This is called the ordinal score, or a semi-quantitative score. But if that score starts going up, your risk of dying goes up as well. So even just seeing it on a CT scan, incidentally, not done for coronary calcium, just done for lung imaging, is very important. And if the radiologists aren't reporting it, then you need to tell them they need to. It's not my opinion, it's the opinion of the American College of Radiology that these doctors should be reporting this routinely. If they see coronary calcium, they should mention that they see coronary calcium, even if it's an incidental finding. And most radiologists, I think, are starting to report it, and they can report it as mild, moderate, or severe, and give you at least some idea if the patient has atherosclerosis, and maybe that'll change your management. So what about this intermediate risk? So 40% of us, if we did our risk calculation, or at least 33% of us, if we did a risk calculation right now, we'd be intermediate risk, which means we don't know. You're not really high risk, you absolutely need treatment, and you're not low risk, you're safe. So this is where coronary calcium can really help. And this is another population-based study called the Heinz-Nixdorf recall study. And they looked at patients in that intermediate risk. And when they did a coronary calcium score, about 1 out of 7 people were high risk. So they weren't intermediate risk. But very importantly, 2/3 of people actually had a score of 0 and were low risk. So those risk calculators overestimate risk, and this can bring down 2/3 of them back down to saying, no, that risk calculator is overestimating your risk, you're low risk. And I'll show you the guidelines. They say you can hold off on things like statin and just stay with lifestyle changes if they have a score of 0 for another 5 to 10 years. I think 5 years is more prudent because things change as we go through and get older. Our cholesterols go up, our blood sugars go up, our blood pressure goes up. People go through menopause and develop diabetes. There's all different things that happen over time. But at least for the next 5 years, you're very low risk and you don't need to worry so much about your immediate heart health. Another study just showing that it reclassifies about 52% of patients. That means more than half the patients got upclassified or downclassified. And in this study, C-reactive protein, again, a biomarker that we don't use so much anymore, didn't add any benefit to the patient, information to the patient. So the biggest benefit, though, bar none, of coronary calcium is going to be compliance. If you get a patient who gets a scan for whatever reason and it comes back positive, they will be a better patient, I promise. There's almost nobody who will not react to this, because this is no longer saying in a population of patients of 1,000 people, 80 people or 100 people may have a heart attack over the next decade, and we don't know which group you're in, but we want to be more aggressive. This is saying you have a lot of plaque in your coronary arteries, and it's time for you to change your behavior. And this works really, really well. So we say a picture is worth 1,000 words, and we can show patients this or tell them that their score is high, and these white plaques in the coronary arteries are good examples of coronary calcium in the left anterior descending, what we call the widowmaker, to scare them a little bit, or the circumflex down here, and we can tell them you've got a lot of plaque, and it's time for you to get on top of this. And this was studied in a prospective randomized trial. This is work from Cedars-Sinai and Dan Berman's group, taking over 2,000 patients and randomizing them to good risk stratification with the risk calculator and advice from a nurse practitioner, or Same thing, but also getting a coronary calcium scan and then adjusting those based on how high the score is. And 4 years later, so this is not like our New Year's resolutions, which have all gone by the wayside by now. We're talking now 4 years downstream. LDL cholesterol was much better controlled if they had a calcium score. Blood pressure was better controlled if they had a calcium score. And Dr. Wright can tell you that while 4 millimeters difference doesn't sound like a big difference between the two groups, when you multiply that times the population, 4 millimeters of blood pressure reduction is actually a big number for decreasing events. And exercise was more, they were still exercising and they were taking more lipid therapy and blood pressure therapy, and they were more adherent to their cholesterol medicines. So it really does help motivate patients to become better patients. And I think that's been the biggest benefit for my practice, because I'm taking people who feel well, and if they're asymptomatic, you can't make an asymptomatic person feel better, but I can at least say, you feel well right now, but stuff's building up in there. Let's get on top of this before the first heart attack, stroke, or cardiovascular death occurs. We did a randomized trial. This is now very old data. They took patients with high calcium scores and randomized them to either a statin or no statin to see if that improved outcomes. And of course, statins work to lower risk. Torvastatin 20 lowered risk by 30% and heart attack and death by 44%. Very much what you'd expect from other primary prevention trials. And if their calcium score was high, back then we called it above 400, the risk was quite significant. And you can see the benefit was 42% overall for heart attack, stroke, and cardiovascular death. So I did this study looking at coronary calcium and trying to identify when is a calcium scan the same as secondary prevention. In other words, what number gets us to that red line? The red line are patients who had heart attacks. And if you look at the event rates, if you had a score of 0 in green, your event rates are very low and you're not at the same risk of having another event as somebody who suffered a heart attack. And that yellow line and blue line are low scores, again, not so bad. But that purple line gets you down to the same level as the red line. And that is a score above 300. So now we can say with confidence that if your score is above 300, you are at the same risk as a patient who's already suffered a heart attack, what we call secondary prevention risk. And now we can start applying some of these new therapies that we have available. PCSK9s, icosapent ethyl, bempedoic acid. We have all these new lipid-lowering therapies, inclisiran, all these new lipid-lowering therapies that are mostly indicated for patients with secondary prevention. And now we can talk about getting them on board in this population before their first heart attack, because 1 out of 3 patients won't survive that first heart attack. So we can't, very Darwinian to say, well, if you live through your heart attack, I'm going to put you on better treatment. And that's what our algorithms say right now, literally, right? Our algorithms say if you survive that first event, you qualify, you're now secondary prevention, you qualify for all these new treatments. And that's silly. But we can't afford to put every single person on every single therapy. But we can now decide based on calcium scoring. And those two numbers now come together. And calcium score above 300, even if you've never had an event, has a similar risk. It can also help us be much better at dishing out therapies, which is going to be very cost effective, not only to get people to actually take them, compliance, as I talked about, but also who really needs them. So this is a population of patients that met all the criteria in the Jupiter study. Jupiter study showed us that rosuvastatin 20 reduced events by 44%. That's a big number. But if they had a score of 0, this is a population that was mirrored in this, calcium score of 0, you need to treat 550 patients for 5 years to prevent 1 event. That's a pretty bad number needed to treat. That's a lot of wasted therapies and a lot of time and energy spent and money spent treating patients. But if the same population had a calcium score above 100, that number needed to treat goes from 550 down to 24. We treat 24 patients for 5 years, and 1 of them doesn't have a heart attack, stroke, or die. So we can be much more judicious and appropriate in who we treat, even with simple things like statin therapy. What about the score of 0? Shouldn't you treat anybody with high risk with a statin? Because eventually they might develop heart disease, and we want to stop that primordial prevention. We want to stop that early prevention of heart disease. And I would tell you, at least for a decade, it is futile. And it's not my opinion. It's another long-term study. This was done at Walter Reed, another closed healthcare system with 12-year follow-up. And this curve represents about 9,400 patients who either took a statin in red or did not take a statin in blue. And if you can see a difference between those two lines, you've got a better eyesight than I do. There was a 0.0% benefit by being on a statin for 12 years if your calcium score was 0. A 0% benefit. Number needed to treat, infinity. You have to treat an infinite number of people to prevent one event. So we have great data. It's not prospective randomized data, because if you wanted to power a study, you would have to be 2 times infinity to actually do the study. That's how many patients you'd have to enroll based on this power analysis, right? You have to do 2x to get a non-inferiority study. So you can't do that. You're not going to study 2 times infinity. But we can say with great confidence in over 9,000 patients, treating patients with a score of 0 with a statin added no benefit at all. But it's not all futile. If we look at the same studies, these are the different risk categories. Look at the patients with look at the patients with a calcium score of 100 down here. Red line being on a statin, event rates. Blue line way up there, not being on a statin. 68% event reduction over 10 years. Number needed to treat, 12. Treat 12 people with a statin and they benefit. So a calcium score can take our number down from infinity, number needed to treat, to 12 with good long-term evidence. What about aspirin? If you know what to do with aspirin in primary prevention, you're a lot better off than I am, because there's a lot of controversy out there, and there's a lot of people who don't know what to do in an individual patient. And the guidelines, U.S. Preventive Task Forces still say if they're higher risk, you should treat them. But there's there's some negative trials now, there's some positive trials, there's a lot of controversy on when to use aspirin in primary prevention. Nothing to do with post-MI or stent or stroke, they need aspirin. But I'm talking about people who've not yet had that first event. But again, we don't want to be Darwinian and wait for that heart attack to say, okay, now you qualify for a drug that's almost free. I mean, you can go to a 99-cent store and get a year's supply of aspirin for a patient. So why not use it when it's appropriate? It's cheap and effective, it works. But we need to know who to treat. So look at these numbers. This is a calcium score of 0. The number needed to treat are in those bars. Either they're low risk in blue or they're high risk according to the risk calculator in red. But when the bar is above that red line, the red line is number needed to harm. And you can see here that there is no benefit. The number needed to harm is higher than the number needed to treat. So we don't want to treat calcium scores of 0 because we'd be causing 5 major bleeds to prevent 1 heart attack. That's not a good risk benefit. But look at the far right, calcium score above 100. Number needed to treat, low. Number needed to treat is about 80. Number needed to harm is about 400. You're going to prevent 5 heart attacks for every 1 bleed you cause with low-dose aspirin. So calcium score above 100 now in multiple different societal recommendations, including the American Society of Preventive Cardiology, which we'll hear from the past president next, is very low risk and very, very prudent. And we should be using aspirin, low-dose aspirin in patients with calcium scores above 100. So it helps us with statins. It helps us with other therapies like PCSK9s and other treatments. It also helps us with aspirin therapy. So it can improve delivery. We can match intensity of risk with intensity of therapy. 50% or more patients will have a score of 0, and we can now maybe put their mind at ease. I'll show you the guidelines in just a moment. And we now can improve compliance and get low-risk people, asymptomatic people, to behave better and follow our diets, our exercise, our lifestyle changes. The one thing we've not been able to change with a calcium score that's positive is smoking cessation. Luckily, California came up with a new plan to get people off of tobacco, and that was legalizing marijuana. So that's a new algorithm, but that seems to be working. So where are we now in the guidelines, and what do the guidelines say? And these are the American Heart Association, American College of Cardiology cholesterol, multisocietal cholesterol guidelines published in 2018, and they simply say that if the coronary calcium is 0, it is reasonable to withhold statin therapy and reassess in 5 to 10 years. That you don't need to treat those patients. And if the calcium score is above 100 or higher, or in the 75th percentile, in other words, they have more calcium than expected for their age or gender, then it's reasonable to initiate statin therapy. So it's in our cholesterol algorithms of treatment, and it's in our appropriate use. These are what tests to do for patients who are asymptomatic. And you can see green is good, yellow is maybe, and red is probably not beneficial. And you can see the only things that have green is either to do nothing or to do a coronary calcium scan. Right? So coronary calcium scan did the best of all of them if you total the numbers, and you can see, especially as you get up to higher risk patients above 7.5%, doing nothing is only maybe appropriate, whereas a coronary calcium scan is appropriate. So we want to start thinking about this, doing stress treadmills or nuclears or CT angios or cardiac caths in asymptomatic people is generally not acceptable or not appropriate. So calcium scoring, intermediate risk, ASCVD risk of 5 to 20%. If they have that low intermediate risk and the risk is uncertain, coronary calcium score will help you decide. If they have a family history, we don't know the genetics of heart disease. We have no idea if you got the genes from dad or mom who had an early heart attack, or if you got genes from somebody else who just didn't get the gene and you don't have heart disease. Coronary calcium will tell you if you have the gene, because if dad had an early heart attack and you have a lot of coronary calcium, you probably got that gene from dad or mom. Statin reluctance or intolerance, if remarkable. There are patients who say, I'm not going to take a statin, I'm concerned. You get them on a calcium, you get a calcium score that's high, they're like, maybe I'll try that statin, maybe I'll give it one more try. And somehow they tolerate it because now they have heart disease and it's no longer theoretical. Again, I talked about non-statin use, things like icosapent ethyl and PCSK9s, and now we have even more good therapies that we could use when we find a lot of plaque. Aspirin, motivation, might even help us with some of the diabetes therapies as we move forward. Now, cautions, it's not a test for everybody for sure. Younger patients under the age of 40, generally not a good idea because they might not yet have calcification. And this is a population I'll talk about briefly with CT angiography as a potential use. And don't go straight from a high calcium score to the cath lab, because even if you're an interventional cardiologist, you're going to be disappointed. About 80% of the time, they're not going to have significant blockages. They have a lot of plaque in the artery. The artery is filled with atherosclerosis, but it doesn't mean there's a high-grade blockage. If there's a high-grade blockage, they probably have symptoms. So if they're asymptomatic with a high calcium score, we treat them aggressively for risk factors, and we'll hear more about that today. If they don't have a high calcium, if they have a high calcium score and they're symptomatic, now you can start thinking about being more aggressive with that population. So let me just real quickly take you through an alternative or CT angiography. CT angiography gives us a lot more information about things like the plaque burden and the stenosis severity, and we can see the necrotic core, and we can see positive remodeling, all of these things that make a plaque vulnerable. And it works. If you get a CT angiogram and you put dye down that coronary, you can see plaque distribution. But if we just see calcified plaque, that's not necessarily the type of plaque that ruptures. It's the patient that has a high calcium score. But if you start seeing fatty plaque, or what we call necrotic core, low attenuation plaque, this really fatty plaque that's very vulnerable, those are the patients who went on and had acute coronary syndromes. So CT angio is better than a calcium score at risk stratifying. We're just not quite proven yet that we should be doing it in patients as a routine test, and the guidelines don't yet embrace it. You saw the appropriateness criteria for CT angio said not yet appropriate. But it does better than calcium scoring. In blue is risk factors alone. This is area under the curve. That's your risk. In yellow is CT angiography, and in red, is calcium scoring, and in red is CT angio. So CT angio predicts events better than a calcium score, and calcium score predicts events better than risk factors alone. And we can do these beautiful pictures now for a pretty low radiation dose. So it's no longer, egregious to do a CT angio. And for young people, this might be a good test. If you have a high concern for somebody and they're under the age of 40, we tend to do CT angiography. It is more involved. They have to get contrast in the vein. It takes a little more time. But we can see now this non-calcified plaque and maybe act on it differently. And in young people, there may still be some value in knowing that they have this big atheroma, this stuff right there next to the left anterior descending. So CT angio for risk stratification, not quite there, but we're going to know soon because, because of these studies. These are the studies that are going to inform us, and they're all ongoing. And there's actually another study called Transform now that's also just started. So we're going to have 4 different trials that are going to look at CT angio versus standard of care in asymptomatic people. And is that going to inform us as to whether or not it's helpful to improve risk stratification, and it'll help us guide therapy. Until then, calcium scoring for asymptomatic people, CT angio for symptomatic people generally, with some crossovers depending on the individual case. So right now I would say, given the lack of outcome data with CT angiography in asymptomatic patients, guidelines support coronary calcium as a first-line test, but younger people where calcification is less common, and possibly patients who are very high risk, young type 2 diabetics, family history, familial hypercholesterolemia, may benefit from CT angio with that added information. So selective use. And I'll leave you with this. This has been my battle over the past decade or more, maybe multiple decades, but this is from Arthur Schopenhauer, a philosopher of the last century. All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. Third, it's accepted as being self-evident. And I didn't get the ridicule. My boss, Bruce Brundage, got ridiculed for introducing coronary calcium. I got the violent opposition. I had to do all of those nasty debates and try to stand up for coronary calcium. And I think now we're finally coming out the other side. And I'll just leave you with one more thought that goes back even further than last century. This goes back about 4,000 years ago. I'll read you the English. My Chinese isn't that good, but this is from the first Chinese medical text. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. That's subclinical atherosclerosis. That's things like coronary calcium and maybe CT angiography. And inferior doctors treat the full-blown disease. And I apologize to my interventional colleagues. This is not my thought. This is from Chinese doctors a long time ago. But obviously very important work. But we'd like to start getting at this process a little bit earlier, and at least we can move up to being mediocre in the eyes of the ancient Chinese with a calcium score. So thank you very much.